Ladies and gentlemen, dear colleagues, let me to introduce our next ISN webinar organized by ISN Academy. And this webinar is related to the very important topic, which is of greater and greater interest with the availability of new drugs interfering with the system. And this is the role of complement in glomerular disease. Until recently, we believe that complement plays a role only in some rare kidney diseases, but now we know that it is very important also in much more common kidney diseases such as vasculitis, lupus, or IgA nephropathy or membranous nephropathy. And today we will have time to discuss two of these diseases, ANCA-associated vasculitis and lupus nephritis. We have two excellent speakers, Dr. Juan Mejia Villet from Mexico. He will speak on lupus, and Dr. Silke Briggs from Manchester, and she will speak on ANCA-associated vasculitis. We will be happy if you contact us with questions. There is a place for question and answers, and we will have short discussion at the end of each individual lecture using the questions related to the lecture. And as we have relatively relaxed time, I hope that we will also have time for some general discussion at the end. And now I can ask our first speaker, Dr. Mejia Villet, to start with complement role in lupus and lupus nephritis.
Thank you. So I'm going to share my screen. There we go. Okay, thank you. First of all, thanks very much to the ISN and KDIGO for the invitation to this webinar. And thank for Professor Tesar for his kind introduction. So I have no conflict of interest with this talk. And as you know, there are unmet needs in lupus nephritis, in several aspects of lupus nephritis, and particularly the results of therapy are far from ideal. And many patients still progress to end-stage kidney disease. And many patients have consequences from our therapies and have adverse events. So we need better therapies and safer therapies. And today we'll look at the complement and see how this pathway is an interesting target in lupus nephritis. Before going to that, I will share with you my view of pathophysiology of lupus nephritis. So to have lupus nephritis, we first have to develop lupus. And patients with lupus have difficulties clearing the immune cells and debris from the circulations. So they start getting autoantibodies and forming immune complexes. These immune complexes may circulate to the kidneys or even form at the kidneys, and they will exert an inflammatory response. And this is when we usually see them on clinic, with all the clinical manifestations and with complement activation. And finally, lupus goes into a chronic phase, either with treatment or following its natural course. It will go into a repair phase or fibrotic phase. And if the second is the one, then you go into chronic kidney disease and loss of kidney function. Going to complement, you know that complement is a mechanism of defense for our bodies against microorganisms, and it can be activated through three different pathways. The first one is the classical pathway, and the classical pathway is activated by antigen and antibody complexes, just as immune complexes in lupus nephritis. So they bind to the C1 complex and activate the pathway. Another way to activate complement is by the lectin pathway. And this pathway has several proteins that have terminal domains that can bind to sugars in bacteria, but also in apoptotic cells. And once they bind to those cells, they next bind to MASPs or mannose binding lectin activating serine protease, and then they can activate C4. So when we measure serum C4 in our patients, we are looking at activation of complement by the classical or the lectin pathway. A third way to activate complement is by the alternative pathway. And this pathway, you know, is continuously activating by a tick-over mechanism and also inactivating. But once in contact with activating cell surfaces and with the help of some other proteins like factor B, factor D, the alternative pathway is a potent way to activate complement. And all three pathways join into a common pathway in C3 and C5 activation. Finally, this pathway will exert its functions or damage through three mechanisms. The first one is by forming the membrane attack complex, and that forms pores into the cells and produces cell lysis, but also by producing some complement fragments like C3a and C5a that bind to their receptors in immune cells and attract some inflammatory cells and produce inflammation. And a frequently forgotten function of the complement is that many of these particles can function as opsonins, particles that bind to the surface of the cells or cellular debris and mark them for clearance from the circulation by phagocytosis. And finally, there are multiple inhibitors of these pathways. So this complicated figure can be seen like this. And this is the scheme we will be using during this presentation. You can see above the three ways of activating the complement pathway and below the three mechanisms of action of the complement: inflammation, cell lysis, and opsonization. So let's go first to why the complement has a protective role against developing autoimmune diseases. And this is because we observed from many years ago that mutations in some complement proteins, particularly those in the early classical pathway like C1 and C4, predispose patients to developing lupus. And this has also been corroborated in animal models with knockout for C1 or C4 proteins. And these mice models develop lupus, and many of them also lupus nephritis. And more recently, also mutations in the early lectin pathway have shown a higher risk for developing lupus and lupus nephritis. So as you can see in this slide, there are multiple ways of predisposing to lupus. So the effects in opsonization, and this is on particles in the early classical or lectin pathway, facilitate the development of autoimmune diseases. And this happens because these particles usually bind to cellular debris in the circulation, and once bind, they mark this cellular debris for removal by macrophages, erythrocytes, or any cell that has the complement receptors. In fact, in the circulation, the CR1 receptor, 90% of the CR1 receptor is in the erythrocytes. And interestingly, CR1 is also present in the podocytes. So if we don't have these particles, opsonizing particles, or their levels are too low, then the cellular debris will remain in the circulation, and patients with predisposition to develop autoantibodies will form immune complexes. And we saw that these immune complexes will go to the kidneys and produce the lupus nephritis. So there's a protective role for complement, but also there's a damaging role for complement in lupus nephritis, particularly in the inflammatory phase. And I'm going to show, we've seen this through the years by several studies. I'm going to show some studies. First, genomic studies that try to find polymorphisms or gene variations that predispose to developing lupus nephritis particularly. So we've seen that the classical pathway complement pathway is involved, and also its inhibitors, but also proteins in the common pathway, in the alternative pathway, and the lectin pathway may predispose to develop lupus nephritis. So as we see in this slide, any of the pathways may be involved in producing lupus nephritis. Let's move now to tissue transcriptomics. And these studies try to see what genes are expressing directly in the kidneys of patients with lupus nephritis. And again, many proteins from the classical pathway, genes are overexpressed from the classical pathway, but also in the common pathway and also in the alternative pathway. And interestingly, the inhibitors of the complement are decreased. So any of the pathways leads to developing lupus nephritis. And what about mechanisms? Well, there are many studies showing that C3A, C5a, and their receptors are overexpressed in the kidney tissue, but also the membrane attack complex is overexpressed in kidney tissue, and this is particularly true in the tubulointerstitium. So any pathway or any way of producing damage is involved in lupus nephritis. Of course, not in every patient, and this is what is difficult in lupus nephritis. And finally, I want to show you these studies. We usually in clinic look for proteins that deposit in the kidneys. We usually see C1q and C3c in the biopsies of our lupus nephritis patients. Some other groups routinely stain for C4d, and it's interesting that C4d deposits following the same pattern as the lupus nephritis class. But many other groups have shown particles from the alternative pathway or proteins like properdin, and particles or protein from the lectin pathway. So again, lupus nephritis may be triggered by any of the pathways and by any of the mechanisms of damage. We have seen deposits of the C3a and C3a receptors in the glomeruli and of membrane attack complex in the tubulointerstitium. So what to get from all this? Of course, it's pretty evident that complement activation participates in the inflammatory phase of lupus nephritis. I'm not going to talk of animal models, but inhibiting complement in animals prevents damage from lupus nephritis. So what is the actual problem? The actual problem is heterogeneity. And it's heterogeneity between patients, because some patients are activated through the complement is activated through the classical pathway, some other through the alternative. There may be a combination. There may be one in the glomeruli, other in the tubulointerstitium. And we lack biomarkers to know which pathway is active and which mechanism of damage is acting in each patient. And before going to treatment, I want to show you why in that chronic phase of kidney disease, when fibrosis develops, there's possibly involvement of the complement too. And the rationale is that in many proteinuric diseases, it has been shown that filtered proteins activate complement that deposits in the tubulointerstitium. And you can see in the image how the membrane attack complex can be found in lupus nephritis, but also in diabetic nephropathy. Particularly in lupus nephritis, these deposits of the membrane attack complex have been associated with a worse prognosis and have been shown to happen even in patients without active inflammation, patients with chronic biopsies. And we know there is a subgroup of patients with lupus that, although has a response, partial response, they remain with subclinical inflammation. They remain expressing some biomarkers, like here I show you a graph for MCP1, and these patients are the ones who progress in their kidney disease. So maybe there's also a role for complement inhibition in this chronic phase, not only in lupus nephritis, but in many proteinuric diseases. So let's jump into complement as a therapeutic target. And moving forward to treatment, there are many questions. Some of them are here. First, we can question which pathway to target. We know that we have to avoid inhibiting the early classical pathway, to avoid inhibiting those opsonins that help eliminate the cellular debris, but it's not so clear if we have to go for the alternative pathway, the common pathway, if we have to go for anaphylotoxins and their inflammatory damage, or to the membrane attack complex, or maybe a combination of them. Many studies have focused on the alternative or the common pathways, as these are the most potent ways of activating complement. Another potential question is what combination of immunosuppressors, because we're going to inhibit complement and we don't want to interfere with the function of other immunosuppressors. And for example, in animal models and in vitro experiments, glucocorticoids, mycophenolate, and cyclophosphamide have shown to decrease complement activation, while calcineurin inhibitors have shown an increase in complement proteins. I don't see a potential problem in this because there can be a synergy or a complementary function of complement inhibitors with these medications. However, rituximab and many monoclonal antibodies, once they bind to the B cells, they exert their action by using complement, by complement-dependent cytotoxicity. So if we inhibit complement, then we will be antagonizing the functions of rituximab and other monoclonal antibodies, and maybe they won't work as well as without a complement inhibitor. So maybe that's the only combination that is not good to study. And the other thing is when to use. Of course, the most logical answer is to use during the inflammatory phase, but we need biomarkers to show what pathway or what mechanism of damage is active in an individual patient to have better treatments. And as I mentioned before, there may be a role for these medications in the chronic fibrotic phase. So what's active right now in the study, in what clinical trials we have in lupus nephritis right now? There are 4 clinical trials. The first one is narsoplimab, an inhibitor of MASP2 protein in the lectin pathway. Iptacopan, that's an inhibitor of factor B in the alternative pathway. We have pegcetacoplan that inhibits complement C3 protein. And we have ravulizumab that inhibits C5 just as eculizumab does. And I want to also mention avacopan. There's no active trial of avacopan in lupus nephritis, but it's a potential target as it can decrease inflammation in lupus nephritis. So at this moment, there's no indication outside clinical trials for complement inhibitors in lupus nephritis, in classical immune complex lupus nephritis. However, there is one suggestion to use complement inhibitors in a non-classical lupus nephritis, and that is the case for thrombotic microangiopathy. Thrombotic microangiopathy may be found up to 18% of lupus nephritis biopsies. And this is an histological diagnosis showing vessel occlusion that may be secondary to several etiologies. And we have to look for the particular etiology in each patient. And the problem is that TMA or thrombotic microangiopathy is associated with worse prognosis. And many studies have shown the participation of the alternative and common pathways in the development of thrombotic microangiopathy. This is one study from our group, and we measured complement fragments in plasma and in the urine of patients with active lupus nephritis, but also in patients with active lupus nephritis plus TMA. And as you can see at the bottom, you can see that the C3A, BA, C5A, and the terminal, the membrane attack complex are elevated in serum and also urine of these patients. And we had 2 patients with recurrent episodes, and it's pretty clear how these fragments that translate activation of the alternative pathway elevate during the acute episode and then go down at remission, then go up again once there's a new acute thrombotic microangiopathy episode. So these and many other studies led KDIGO to put this algorithm for management of thrombotic microangiopathy in lupus. And the first step is to go to study these patients by ADAMTS13 activity and antiphospholipid antibodies. And in a subgroup of patients with normal ADAMTS13 activity and no antiphospholipid antibodies, there are some patients with complement complement-mediated thrombotic microangiopathy that may benefit from complement inhibition with eculizumab. So this is at present the only indication or suggestion to use complement inhibition in lupus. So the take-home messages are, first, we have to acknowledge that there's a protective role of the complement pathway against development of autoimmune diseases. It is pretty clear that during the inflammatory phase of the disease, complement is activated. The problem is that there is large heterogeneity among patients, and we need to find biomarkers to get to an individual treatment. Current studies of complement inhibition are focusing on the alternative, the lectin or the common pathways. And keep in mind that there may be a role of complement inhibition in the chronic phase of every proteinuric disease. And for now, the only indication or suggestion to use complement inhibitors is in the cases of complement-mediated thrombotic microangiopathy. And this is all for me. Thanks for your attention and thanks for your questions.
Thank you, Juan, for this really very nice and excellent lecture. And we have here several questions from the auditorium, which I try to interpret. There is a question concerning the levels of C3 and C4 in pregnancy. So if C3 and C4 levels are influenced in lupus patients by pregnancy.
Sure, yes. And that's an important point because in pregnancy, many proteins that come from the liver are, their production is increased.
Mm-hmm.
So these patients in pregnancy usually have higher C3 and C4 levels, and maybe a C3 and C4 level in the normal range, but in the lower normal range, maybe an indication of active nephritis, and it should be taken into account.
And the second question concerns the levels of C3, but there is also C4 in remission and relapse. So I think that it is meant if there must be normal C3 for in remission, and then if any decrease of C3 is to be interpreted as relapse. And one related question to that is if the decrease of C3 may not be caused by the concomitant infection.
Yes, and these are good and difficult questions. I did not speak about biomarkers, but we usually use C3 and C4 levels in clinic. The problem is they are not perfect. Particularly, the first thing is that they are circulating proteins, and as that, any level of activity at any other organ may affect C3 and C4 levels. So there may not be a specific for the kidneys. Another thing is that after treatment, many patients remain with low levels. And we have shown, investigators have shown associations of remaining with low levels and relapses, remaining with low levels and prognosis. But the thing is, when we go to an individual patient, these this complement C3 and C4 may fail in some patients. So the best recommendation is to follow them and see the trends, and that may help in each patient. There are some patients with low C4 levels along their course of the disease, and it may not be a good biomarker. And I just forgot the second question that's about C3, I think.
It was about the influence of infection of
yes.
levels, yeah.
Yes, of course, and that's another thing. As these are circulating proteins, infections that lower C3 levels can also confuse us when we evaluate an individual patient. So that is why we have C3, C4, and we have double-stranded DNA antibodies as biomarkers. Well, we need better biomarkers or more specific biomarkers.
Do you also use anti-C1q antibodies as markers of renal relapse?
We use them more from a research perspective. These have very low sensitivity. That is, there's only 30 to 40% of patients with C1q antibodies, but they are pretty much specific for lupus. but they also fail to work as well for the management of the patients long term. So they cost a lot. So maybe it's not a cost-effective way to monitor our patients individually at this moment, I think.
Use them quite routinely, and my experience is that as you said, that they are very specific but not very much sensitive, yeah, for the diagnosis of renal relapse. And there is a question: what kind of complement inhibition you would recommend to the patients? I see that you already responded that is based on which complement pathway is activated, but sometimes it's not so easy to evaluate it. And probably you should also comment on the advantages and disadvantages of inhibition of single pathway and the combination of, for instance, C5, which at least in my opinion may be associated with higher risk of infection than you inhibit on the specific pathway. Is it the case?
Yes, that's the thing. And I was trying to express that there's a very high heterogeneity, and this is what happens all the time in lupus. We name someone class 3 or class 4, but there are very different kinds of patients. There are patients with a lot of leukocyte infiltration in there, and maybe there's a role of C5a inhibition in there, receptor inhibition for avacopan. But there are some other patients with a predominant vascular phenotype, and probably there's a lot of membrane attack complex activation in there, and maybe that's a good patient for a C5 inhibitor. So we name every patient as class 3 or class 4, but there are multiple pathways possibly involved. So it is difficult at the moment to know which individual is activating which pathway. So if we go very downriver, or we try to inhibit the common pathways, maybe we avoid the inflammatory and the membrane attack complex functions, but with the cost of infections. So for me, it is difficult right now to, of course, I would not recommend treating patients right now outside clinical trials. We have to see what happens with clinical trials. Maybe the ones going up in the alternative pathway, as this is the most potent pathway, have I hope they have good results. But in very inflammatory cases, I would also want to see what avacopan has to give in lupus nephritis. Hopefully, we'll have a clinical trial in there.
Thank you very much. We have some other questions, but we have not time for them now, but we can return to them at the end of the webinar, because it's time to start with our second presentation, which is to be given by Dr. Silke Briggs from Manchester, and she will speak on the role of complement inhibition in ANCA-associated vasculitis.
Thank you, Vladimir, for the introduction, and thank you, Juan, for having that great and detailed overview in complement. That makes my job now much easier. So I'm very pleased to talk about the role of complement in ANCA-associated vasculitis today. And first, my disclosures. And looking into the objectives for me today, compared to our first workshop with C3 glomerulopathies, where you got a good overview and detail of the KDIGO recommendations in C3 GN. It's a bit different today because the last KDIGO recommendations were drafted before FDA and EMA approval of avacopan. So this will be more about how much do we know is the complement involved in the pathophysiology in ANCA-associated vasculitis, and from there, what clinical trial results do we actually have, coming to that one big interventional trial. And then I will only touch on what complement inhibition is in or not in KDIGO and the about to be released EULA recommendations. So first of all, is always the questions, why discuss this at all? I think we all know our patients are suffering a multi-organ disorder, and most of them are miserable. And perhaps we concentrate as physicians more on the clinical scenario and the severity of the disease. So we're very worried about diffuse alveolar hemorrhage, crescentic GN. And we could say we're getting better. But if you look at this here, while there is an improvement in survival over the last decades, we are not able to be satisfied. We're far from allowed to be satisfied. If I just concentrate with you on the last Pexivas data here, and we'll just focus on the first year survival, there is a 25% chance that our patients develop end-stage kidney disease or die with rituximab or cyclophosphamide adding in plasma exchange or not. So that is not okay. And it becomes more and more important to reduce toxicity. So again, if we're now looking at reducing steroids here, the long-term outcome might be even better if we use less steroids. But the short-term first-year outcome is certainly far from us being able to be satisfied. So there's a great unmet need for us to improve. And that's why something like the complement inhibition has become such an important aspect in ANCA-associated vasculitis now. And we could say, why have we not looked into complement inhibition earlier? And I don't think we need to blame anyone on that, because if we look at how we define our diseases and look at how we divide our rapidly progressive glomerulonephritis, remember that it's easier to look at type 1, where you have this nice linear deposition of an IgG that directly activates the classical complement pathway in anti-GBM disease, or the type 2 immunocomplex diseases. As Juan just pointed out, there's so much deposition of so different immunocomplexes and complements that no wonder you actually wonder where the mechanisms is and what to block, compared to what we set to our disease, ANCA-associated vasculitis causing post-immune disease. And post-immune meaning that that tiny bit of complement deposition we perhaps see is a mild C3 that in an EM only leaves a vague, sparse deposit. And so no wonder that we perhaps delayed got involved with complement inhibition. But if we look into stainings first, post-immunity does not mean non-immunity. And on the left side, you see the complement pathway here, from my side, very simplified. And I would want us to just concentrate on, we have the alternative pathway as AP, the classical pathway as CP, and then downstream with the C3 convertase, we'll have the release of anaphylatoxins like C3A, and further downstream C5A and their receptors. And novel complement factors and staining of other factors than the two classical factors we routinely stain, so not staining C1q and C3, but staining other factors in the last years, has hinted at that there's some involvement of complement, because the so-called post-immune ANCA-associated vasculitis, they don't look so post-immune if you look at these stainings. And these are just examples of C3d staining, or a complement factor H related to protein 1 staining from the complement factor H related protein family. So post-immune on the biopsy, perhaps hinting at this has some mechanism from complement involved. Looking into soluble complement factors, there was also the idea, oh, perhaps we should look into complement. Certainly not, as Juan pointed out, we have this very deep depletion and association between C3 and C4 and the clinical picture in lupus. Far from that, in ANCA-associated vasculitis, you rarely, in a small group, see patients where you do detect the C3 depletion when these patients have active disease. No, you rather have a tiny bit of an increase of C3 and C4 as a general sign of active inflammation, but most of the time you don't find C3, C4 changes in ANCA-associated vasculitis. But I just want to point out, this publication, if you look into more the cleavage products, other complement factors that have been released, that could be a hint what complement is involved in, because in active vasculitis, it was proposed that you do have more C3A and C5A release, and that this calms down when people are in remission. But certainly looking at these hints, the most important studies that have moved towards complement inhibition and increased our knowledge have been the animal studies. And despite all the limitations of these animal studies, and I have just examples from 2 animal studies. One is from the Chapel Hill group, from Professor Charles Jeanette's group, where using a passive Mpo transfer model, despite the limitation of passive immunity and not being an active immune model, this model has clinically, not just in the kidney with the crescent formation, but also in the lungs, nice clinical features, what we find in our patients. So what the group from Charles Jeanette did is they first had to look and inhibited the classical complement pathway, and inhibiting the classical complement pathway here, C4, and using a knockout mouse for C4, they did find no difference in their mice. These mice were as affected as the wild type. And then depleting the C6 factor as part of the membrane attack complex C5b to 9, this did not affect the mice either. So these mice showed the same amount of disease with crescent formation. So that was the first sign. No, the classical pathway is not going to be the one we need to concentrate on. And then not just Charles Jeanette, but also the group of Ralph Ketritz and Adrian Schreiber looked into the alternative complement pathway. And while Charles Jeanette used a knockout mouse for C5, Adrian Schreiber and Ralph Ketritz used a knockout mouse for the C5a receptor. And using mice without the ability to bind C5a, indeed, what they found is that you see on the right side, the wild type with the crescent formation here and here. And their C5a knockout mice were protected. So these mice did not develop the disease. Quite impressively, they did not develop crescents and necrosis. So that was the first sign, okay, the C5a receptor axis seems to be involved. And how can we now have a look in humans? What would these factors be used of which effector cells? And most prominently, we know this is a leukocytoclastic vasculitis. Neutrophils have a long-term been implicated as being powerful in this disease. So if we look at our neutrophils, we do know that neutrophils activated by ANCA release reactive oxygen species. And here, inhibiting the C5a receptor in neutrophils activated by PR3, there was a significant reduction of reactive oxygen species. And further, looking into C5a, where does that come from? Well, so it's not just the C5a binding of the neutrophil, but if we look into neutrophils activated with ANCA and then measuring in the supernatant C5a, these neutrophils released a significant higher amount of C5a when they were activated by ANCA. So mechanistically, how do we feel this is going to work? So we have our neutrophil that A releases complement factor 5a when it's activated, binds it, and then what does it do with it? So we know NETs are involved in ANCA-associated vasculitis, and we see that ANCA induce NET formation in neutrophils, but co-incubating the NETs induced by ANCA and then co-incubating that with human sera from patients, that actually came to a higher release of C5a. So that we now believe that the pathophysiological processes of ANCA-associated vasculitis are like this. We have our neutrophil crawling along the glomerular capillary and patrolling, and some pro-inflammatory stimuli now prime these neutrophils. And this priming process means that they overexpress Mpo and PR3, they come to the surface and they are visible there. And after loss of tolerance and us developing ANCA, these ANCA can bind the neutrophils, and that's the activated neutrophil. And this activation process then has the neutrophils releasing C5a binding C5a on its receptor. And this is the amplification loop that has done more neutrophils recruited, more primed and activated, and resulting in binding of neutrophils with degranulation, netosis, and the leukocytoclastic vasculitis. And with these results, the C5a receptor 1 inhibitor CCX168 called avacopan went into phase 2 trial. And I just have the two most important results from there. So giving patients either in green avacopan or in red avacopan with low dose steroids did even show an impressively bigger reduction in your BIVA score of activity in patients compared to the high dose steroids. So a feeling that you could perhaps replace the steroids with avacopan. And interestingly, what we often see when you start treating patients and have a temporary rise even of proteinuria, this did not happen in the avacopan arm or in the arm with avacopan and low dose steroids. Mechanistically not really telling us is perhaps the toxic effect of steroids and the hyperfiltration causing some protein increase leakage for a time that we don't find, or is it just a better control of the disease? But certainly some interesting results. And in the phase 3 trial now, important is, I think, that I show you the design. What was compared was 30 milligrams of avacopan twice daily with a steroid arm. And while the first 26 weeks, there was a double-blind, double dummy, avacopan with steroid dummy compared to a placebo with steroid. The steroids were withdrawn in that arm at 26 weeks, while the avacopan carried on for the remaining time of the study to the full 52 weeks. And the outcome of that study was that patients did have a similar outcome after 6 months of avacopan compared with steroids. So you were able with avacopan to avoid steroids and replace them and had the same remission rate. And withdrawing then steroids after 360 days, after the full year, avacopan was superior to the arm where steroids were withdrawn. And this has then led the FDA and the EMA now to license avacopan Tavneos in combination with rituximab and cyclophosphamide in severe ANCA-associated vasculitis. And so I come to my last part. This is how has this now featured in the KDIGO and EULAR recommendation? And I must say it hasn't featured in the KDIGO because KDIGO was drafted before the FDA and EMA license, but it's just featured now in the up to date of the EULAR recommendations that are to come out any day now. And I think if we look at KDIGO and EULAR, we all try to incorporate a bit more the frailty aspect and the severity aspect. But it looks still pretty much like this. So the KDIGO recommendations are using rituximab in non-life-threatening disease. They give the option of MMF, and in more organ life-threatening disease, rituximab or cyclophosphamide, while KDIGO gives you the option to combine rituximab and cyclophosphamide if you feel it is very severe. Then you add glucocorticoids, and the new EULAR guidelines will say you can consider to replace steroids or avoid steroids overexposure and add in avacopan. That wasn't in the KDIGO from last year. Both recommend that we can consider plasma exchange, going back to the severity of the disease, while KDIGO says dialysis dependence, creatinine over 500 to consider. EULAR will say from a creatinine of 300, and if you feel you know this disease is driven by an active glomerulonephritis on the biopsy, then consider plasma exchange as escalation. And KDIGO as EULAR have started to recommend in frail patients to use rituximab then as maintenance, and EULAR will even recommend first-line rituximab as maintenance. But certainly azacitidine remains the option to that. So summarizing that, I would just quickly like to look forward and say, well, perhaps at some point we'll be able to intervene at the time of loss of tolerance. We're far from there, but we have, I think, already moved now to one further step. We are able to interfere early when C5a is activating and bringing the disease on the neutrophils. The future will show the efficacy of that intervention, and will hopefully open up certain more pathways involving different alternative complement factors, but also have us looking at degranulation of neutrophils and netosis closer and other cells. And with that, I'd like to summarize. So the deposition of complement in the kidney, and certainly the raised soluble factors as well, have, I think, probably already suggested that alternative complement pathway is involved in the disease. But now we do know that the ANCA-induced neutrophil activation that happens is C5a dependent. And we know that NETs activate the complement and the ANCA dysregulate it, so that this positive feedback loop of these three altogether, the alternative complement, the ANCA, and the neutrophil, they drive that endothelial inflammation in ANCA-associated vasculitis. And I've shown you that we've seen in animal models that C5a receptor inhibition was able to completely inhibit the development of the crescentic GN, and that the phase 3 trial now has shown that inhibiting C5a receptor binding is non-inferior to prednisolone in 23 weeks and superior after you withdraw steroids. And that means we can reduce glucocorticoid toxicity, we can hopefully replace it, but I would hope that we also will be able at some point to further improve outcome of patients, and that demands that we have further trials inhibiting the alternative complement factors, and that will hopefully demonstrate how the efficacy of C5a receptor inhibition and investigate further routes. And then I thank you all for the attention, and I'm looking forward to the questions now.
Many questions, many thanks for this nice overview. We have also many questions after that. And I would like to comment in the beginning that we have also a new approach from KDIGO, which starts to work on the update of the chapter both on lupus and both on ANCA vasculitis, and we expect that there will be some updated chapter available in probably the beginning of the next year. So we will definitely be also inspired by EULAR. And there is also a study with anti-C5a antibody in ANCA-associated vasculitis, which also may bring interesting results. And possibly, based on what you showed, also iptacopan could work in patients with ANCA-associated vasculitis. Yeah. And we have some questions from the auditorium. One was already asked with registration, and this is what you think about ANCA-negative vasculitis and how these patients should be treated.
I saw that question. This was about how confident we feel to diagnose an ANCA-negative vasculitis. And I must say, I think that just brings us all to the limits and to the importance to not feel too overconfident, whatever you do, and always remember to review your assessment and be able to change your opinion as needed, because especially if you have ANCA-negative patients, you rely even more on the biopsy and on the response of your patients to treatment, right?
Yeah, so this is mostly diagnosed by renal biopsy, both the immune glomerulonephritis with ANCA negativity. And these patients quite frequently have limited extrarenal involvement. Yeah, and it is probably more frequent in Asian than in European patients, is it? Yeah.
It could be that they're biopsying more than we do and we miss more, but yeah.
Okay, so the second interesting question is, when we see the activation of alternative pathway in ANCA-associated vasculitis, why C3 is normal in most patients. Yeah, or at least in normal range.
Yeah, and to be honest, I think that there was nice data initially showing that there's a small cohort of patients where you do find some C3 depletion, and I usually like to therefore routinely do C3, C4, and I hardly see ever a patient who has a low C3 with an ANCA flare, but there is a small cohort where I think they do have more of a TMA overlap, and they tend to sometimes have a tiny bit of TMA, and this cohort certainly then has this C3 depletion more likely. I think what more often is that you have a borderline normal or even higher C3, C4 as sign of your active inflammation. So I don't see a true depletion often, no.
There are several other questions concerning avacopan. The first one is when we can expect that avacopan is available in the UK and in Europe.
Yeah, so with the EMA license now, a lot of European countries can move forward, and I've heard of colleagues who are able to use avacopan, and it will come to your individual countries. How is this going to be placed in your hospital county side to talk about cost effectiveness, or is this going to be more from a countryside like in the UK, where we certainly have MHRA and NICE recommendation pending for August to tell us are we going to be allowed to use it or not? But some of the European countries, certainly Germany, you would be allowed to start avacopan in your patients.
Possibly it could be more cost effective, and this is also one question in patients with more advanced kidney disease because of the effect of avacopan on EGFR in these patients.
Yeah, I mean, one limiting factor is that the phase 3 trial excluded patients with an EGFR below 15. The worst cohort, we don't know how well this will in addition help, and we all are hopeful that avacopan would help us to reduce that end-stage kidney disease rate and would help in the most severe patients. I think as these patients get all more complex and more multimorbid, we have to take into account that cost effectiveness is perhaps even far more prominent going to feature with avacopan than we think, because of all the complications people develop with steroids. When you really closely look at your 65 to 70-year-old gentleman with already diabetes, hypertension, and then having now CKD with ANCA-associated vasculitis, there's a incredibly big rate of side effects that come with steroids and costs as well. So I think we need to be careful. It is an orphan and an expensive drug, but we shouldn't underestimate the power of not using steroids.
And what is also in 2 or 3 questions is the length of treatment with avacopan. So it means that based on the study, we should use it for 12 months. On the other hand, it is well tolerated, could probably be used for a longer time, but we have no data on that.
Yeah, I mean, that is the thing. Having some biomarkers to tell us how long is, especially if it remains an expensive drug, how we're going to use this, because in theory, it would be an early on helper to reduce flare as well. So it would be like steroids, something I would withdraw late and use early again if I need to. And yeah, so this makes it even more difficult of cost effectiveness reason.
And another point, of course, in the corticosteroid, limb corticosteroid were completely withdrawn after half a year. So the difference in relapses may be caused by the absence of treatment with corticosteroids in corticosteroid limb.
Certainly, and we know that from the RAVE trial and using and withdrawn steroids early from the American trial sites, that this causes us to have early relapses, and these patients, therefore, that makes sense.
So I think that we responded to most of the questions related to avacopan and to the second lecture, and we can once again return to some more general questions or questions related to lupus for which we had a limited time. So the one question probably for both speakers is if there is still any place for some old evaluations of complements such as CH50. We do not do that. You still use it,
No.
No. Yeah. So this is an easy question. The second question is if the patient who has with lupus, but it is the question namely for Juan, has the activation of alternative pathway during the relapse, then if we can expect that there will be an activation of the same pathway with subsequent relapse, or if it can change in the same patients, or if it is some kind of characteristics of the patient, the activation of the specific link.
Yeah, that's interesting because there are not so many studies in that. We did with Dr. Robin, we did a transcriptomic study in lupus nephritis patients at a first episode and then a subsequent episode. And we saw that the same pathways were active. So that may shed some light in there, but of course we need reproducibility. But it's potentially that it's a potential thought that one patient follows the same activation pattern every time, maybe, but we cannot respond for sure.
And you already spoke about the putative indication of avacopan in lupus nephritis in patients with some kind of inflammation, yeah. And there is a question why lupus nephritis is so heterogeneous. So why there is an activation of one complement in one patient and another one in another patient? Is it in fact the group of several different diseases?
Yes, I really don't have an answer. It's just to break our heads. No, I really don't know, but it is clear, and you see it on clinic, that there are patients who respond very well for some treatments targeting B cells, for example. And there are some others that don't have a good response to those treatments. And then you go target T cells or some other pathway and they respond. So they are different, and trying to get to that heterogeneity and find a better classification, it's what we need to find before trying to do an individualized treatment plan.
Yeah, so you mentioned that there may be antagonism between rituximab and complement inhibition, but this probably was not the case in ANCA vasculitis with avacopan, yes, because it was the results were similar in patients treated with rituximab and cyclophosphamide. And there is another question: if we should go for multi-target treatment in the beginning, or if we should prefer a kind of sequential treatment, to start with something and to switch to something else after some time.
Yes, we have to understand the phase of the disease we are treating. That is why I try to divide lupus in phases. For example, corticosteroids are anti-inflammatory agents. So I don't like using glucocorticoids once the patient is on the long term of the disease or the maintenance phase, but or not using large doses, for example. And maybe there are some other medications that work well during the long phases. So yes, this sequential idea is pretty interesting. We need to find we now have several other drugs finally to treat lupus. Now we need to find where to use each one of them, where we have to find a place for belimumab, for voclosporin, to combine them. And that probably in the next few years, we will know more information of how to use them.
And we have no direct comparison of this new treatment, so we do not know if voclosporin is better than belimumab, and it will be the case also in other glomerular diseases such as in IgA nephropathy, where so many new drugs are currently tested. And there are probably two last questions for Silke. One is concerning plasma exchange. And the question is, should we give avacopan before or after, or any extra dose post plasma exchange? So there is, of course, no experience in that, but what is your view?
That's the problem. I think not having it tried, there's certainly nobody who can tell you now how you, nobody can tell you, I know. Personally, I think if you think about using avacopan, and if you're able to use it, think first, is this going to help you to not do plaques, right? Either or, kind of what I would feel like. And if you do decide you think this patient could use plaques and you do start plasma exchange, either you just wait the 5 to 7, 10 days before you start, or if you do have the option to use avacopan, having liver metabolism and no data below GFR 15, I think it's really difficult to say. I wouldn't say go and dose extra, because I think there's no data and you don't want to go in. It's an unsafe area where you start overdosing. So I think perhaps then use the dose after plasma exchange on the day, because we don't know how much that impacts. Or you perhaps really just wait until you stopped your plasma exchange and then start Imacobaan.
It is usually not a problem with these drugs which are used frequently in these patients. So it's completely different from, for instance, the combination of rituximab with plasma exchange. And the last question, is there a difference in treatment of patients who are anti-Mpo and anti-PRC positive? Or what is the best treatment in either anti-PRC or anti-Mpo?
Yeah, I think it is quite sad, actually, that in times where we do know from GWAS and clinical observations, these patients are so different. So they are different diseases, that we actually still have all recommendations usually coming out with the same, intent for every patient being the same, and we're very wrong. So certainly MPO and PR3 should be treated differently, and especially PR3, and you have done clinically GPA and ENT involvement, you would certainly say you're not going to try to minimize treatment because you don't want to have early relapses, and your maintenance treatment would perhaps be longer than with an MPO. So I would feel more comfortable with an MPO person who wants to minimize treatment to say, well, I don't know, perhaps you are one of the ones who has a once-off disease and that doesn't come back, let's try this. I wouldn't feel comfortable doing that in a PR3 person with ENT disease. So certainly in the longer T-off treatment and the maintenance phase, there's a good difference between MPO and PR3. I think then there will be subtypes of MPO and PR3 diseases where you have a slow sclerosing. Hopefully I'm not getting another viral infection. No, so there will be a subtype of MPO that is more sclerosing and slowly without so much active disease signs, and that is a different MPO disease from an MPO disease you see clinically can be quite similar to a PR3 disease where something explodes in front of you and needs very aggressive treatment. So I would say we need to do different things for MPO and PR3, but even if we're just looking at MPO and PR3, we again need to do quite a few differences in treatment approaches depending on the individual risks.
Yeah, I completely agree. Thank you very much. So I think that we were able to respond to not all questions, but most questions or most topics which were raised. And I really enjoyed the discussion. So thank you very much to both our speakers for their excellent lectures. And thank you also for the active audience and so many nice questions we got. And I hope that you will also participate in the further seminars and webinars which will be related to complement inhibition in other glomerular diseases and which are currently in preparation. Enjoy the rest of your day. Bye-bye.
Thank you, Vladimir.
Thank you.
Thank you.